I wish to thank Scientific Committee, AIO Scientific Committee for giving me this opportunity and very good afternoon to you all. So I'm going to talk about OCT angiography. OCT angiography has been now with us for years. So we all know that OCT angiography is a nascent, fast, dye-free, non-invasive technique to visualize and assess retinal and choroidal vasculature abnormality. It provides us cross-sectional and en-face images to detect structural abnormalities, perfusion abnormalities, and vascular flow abnormalities. Unlike FFA or ICG that treats retina as a unilayer, OCT angio can detect blood flow abnormalities in superficial, intermediate, deep retinal capillary plexus as well as in choriocapillaries. So then there are diagrams in OCT. What is en-face? En-face is 2D representation of the 3D volumetric data. And different layers of the retina can be are identified as segments, and area between each segment is known as slab. If you move the eye during examination, there could be motion artifacts seen as jagged lines. There could be projection artifacts when the superficial vessels are seen in the deeper layers of the retina. Then there are flow, flow void, and flow indices. Why do we need these diagrams? Because they can act as a quantifiable variable. One of them is foveal avascular zone area, acircularity index, how much your fovea is acircular than acircle. Vessel density, FD300 is foveal vessel density in a 300 micron area centered over the fovea. For fusion density, an extrafoveal avascular area, this is an area of avascularity or flow void area outside the 1 mm area centered over the fovea. So what these quantifiable variables help us with, Rakausis and et al. Suggested that FD300 can act as a sensitive biomarker to detect subclinical diabetic retinopathy, while extrafoveal avascular area in superficial capillary plexus can discriminate between a patient of no diabetic retinopathy from a patient of NPDR. While vessel density, decreased vessel density can be a marker to the patient developing PDR. So in our study and a study by Bailey et al., how did we differentiate between an NVD and collateral? Based on 3 criteria. So one is if you detect an abnormal flow in the vitreous. Second, if you see these, based on the morphology, if you see these rete of new vessels. And while the collaterals are meandering vessels, at the same time, these new vessels in NVD or in NVE are seen in the vitreous plane, while collaterals are best seen in the radial peripapillary plane. OCT angio can clearly demarcate, delineate, and detect all types of CNVM. At the same time, it can identify subclinical CNVM, which are difficult to see on FFA because they don't leak. At the same time, if you see vessel abnormalities in different layer of the retina and you see a flow connecting all those 3, it's a lesion of a wrap. Just remember, segmentation is very important. Sometimes when there is a faulty segmentation, you can detect abnormal vessels which are not there. So faulty segmentation can lead to a faulty interpretation of a CNVM which doesn't exist in the patient of choroiditis. Always correlate your en-face OCT with the structural OCT because those flow void areas can just be a lytic space. They might not be a true flow void area. So look at the structural OCT with the en-face OCT. So OCT angio can also detect vascular flow abnormalities in deeper. So disease affecting the deeper capillary plexus like sickle cell maculopathy and paracentral acute middle maculopathy are better delineated on OCT angio. OCT angio can also delineate these NVs in patients of RVO, retinal venous occlusion. At the same time with the CNP areas, treatment with the laser can be seen as reduction in the size of these NVs, at the same time reduction in the flow. OCT angio can also look at choriocapillaries. So these flow void areas in choriocapillaries in VKH, and resolution of these flow void areas can mark the time where you can stop the treatment in this patient. At the same time, we know that there are multiple white dot syndromes. So OCT angio can delineate by looking at the choriocapillaries that is this a multiple evanescent white dot syndrome, because these white dot syndrome do not affect choriocapillaries. So do an OCT angio in MEVWS and you will not find any flow void areas. Okay. Yeah. So with the availability of newer wide field OCT angio, the disease that used to affect the periphery basically are also taken care of. So diseases like IRWAN, which we couldn't identify, or those peripheral CNP area that lead to recalcitrant DME, can also be treated with the help of OCT angio, because newer OCT can also look at the peripheral CNP areas. Swepsos OCT has a better penetration than the normal OCT. So Brezana et al. Found that if they use Swepsos OCT based OCT angio, they can even delineate a retinal macroaneurysm which was not seen with FFA because of the overlying hemorrhage. So because of the better penetration, you can look beyond the hemorrhages also using a Swepsos OCT. So then there are other places where we can use swepsopacity in chronic CSC to identify the CNVM complex, macular telangiectasia type 2, glaucoma to see the reduction in the blood flow around the disc, and the hereditary diseases. So what I would like to tell you all is, before doing an OCT angio, know the anatomy of the retina, know what you are looking for. Always look at the segmentation. Faulty segmentation, faulty results. Correlate your structural OCT with the ENFAS OCT, because one thing cannot be interpreted without the presence of the other. Use the right screening protocols. A 3 by 3 mm is a best suited protocol when you are looking at the fovea or the inner macula, while when you're looking at the wider field, like you are looking at the patient of an RVO or patient where you're looking for NVE, use a wider protocol like 6 by 6. In fact, now the montage of 14 by 14. Scanning is easy, interpretation is a bit difficult. So practice, practice, and practice and learn. Thank you.
Thank you. Very nice talk, Ankur.
Thank you, sir.
A couple of questions always remain with this high technology tool. There is a lot of fascination is using this, but taking into day-to-day practice, everyday practice. Specifically, see, I'm talking about things like you said, abnormal and normal. A lot of times we discover those silent CNVMs, which are picked up. But do you treat them, or
Nope.
do you just observe them?
So observe them.
Yeah. So the endpoint is not known, even in routine CNVMs also.
So I totally agree with that, sir. Even today, the FFA is still the gold standard. I was discussing with Dr. Malaika yesterday that we can't see diffuse leaks. So if your patient comes to you with a DME of a diffuse leak, how do we see that on FFA? We can't.
Yeah.
So still today, the FFA holds complete value. But when we are looking...
So you made a statement that Octa can't replace FA.
As of now, it has not.
So what is the current role of Octa then?
So mostly the posterior pole pathology, especially ARMD, something when we are looking at the posterior pole per se. We are looking for any new vascularization. We are looking at any, we are looking...
Malika, do you do Octa in all CNVMs?
No. Initially we used to, but we found that it has no correlation with activity or treatment. So not every visit, we might, not at all. But I think more importantly, we use it to confirm the presence of NVD or NVE. We suspect there is a fine NVD. Not sure, then Octa can really show up the new vessels on the disc to add the laser.
I will not, because the thing is, to pick up a subtle NVE, you have to do a laborious job.
NVD,
it's not so. NVD is okay. NVD is okay, yeah. Because 5 minutes or 4 minutes of angiography will reveal more wealth of information regarding this rather than...
Only NVD I was saying.
No, Siddharth?
I totally agree, because FFA still is an investigation which is usually backstage. But I think FFA really is important, and it has an important role in the next talk also. So the role of FFA would be highlighted in the next talk also, where we are going to...
I think the learning curve still remains the biggest challenge. I mean, for a novice person, it does take quite a bit of time to, kind of...
I would just add that this can also be used...
Time is not far away, then we will not be making all these statements what we're making today, that it will ultimately come very, very close to FA. With the flow indices coming up, and with the, this void zones coming up. So I think people have to learn all this so as to become adapted. As of today, most of us are not adapted and use it in everyday practice.
Two places. One, when we are looking at subclinical cases. Second, when we don't want to repeat an FFA, we can do an OCT angio. Thank you, sir.
Excellent pictures.